rust.
Yeah. What was there?
So when you don't you usually go up there once a year? I've been there in decades.
You have a
Gary did that.
Yeah. Nice
My shoulder, I'm probably not supposed to ski, but
But it
I
really
might
makes
try
you
March.
think, that's for sure.
Well,
I have a
amazing.
niece in law that plays
Bowler
Sublingual.
now. Exactly what he's
Yeah, what he's predicted.
Yeah.
How many people need to sign, Lynn? All of us?
Huh?
How many people need to sign?
I don't know, 5.
yeah, celebrations. I don't start work until 9 really.
So whenever you
Here, Al, sign. Here, sign that out.
Thank you.
Gary, you could have told us to pick your pop right out of that book.
Yeah, I did.
I know.
Tons of it was in there. Even, I had that picture of it. I had that picture of it.
It's sort of scary though, you know, we worry about the androgynous thing. It's gonna come from down the street. It's not gonna come from the street. Good morning, how are you? So far, so good.
Like Bali, the same airport with a same
It's the first year we didn't have any kids around. It's really strange. So my oldest is in his wife's parents. They're
It's a little
baby.
town.
And my youngest went to her boyfriend.
Panda, maybe it's a panda or something.
He wasn't able to go home because his mom's on chemotherapy. Christmas Day, we woke up and said,
You know where Bali is?
what do we do?
Up the just
Her boyfriend lives in Seabeck,
and
so
then
they're
go up there to
close. And then Derek is in Virginia, so he was going. And then my middle son, he said, well, we're not all going to be together tonight, or we're. That was.
I forgot you've been to Thailand. You go south of Thailand.
Yeah, but it's more going to have to get used to it.
When I remember back, as green as I was, worse. Two of us.
He's good, yes. I wouldn't trust that person. No, that's always a risk.
It's just like.
Yeah, right. No, we'll just give Nora.
Good morning. How are you? Tell me when you're ready.
Good job.
Oh, it's going to be great. Well, you was good at the show.
Oh, isn't it
So ours was easy.
They made it up to skiing yet?
Yeah, Stevens was fine. They closed yesterday. They're ready.
And over to beach from and then we went to Cyprus.
Interesting seeing so far. They did a lot of
Pandora on the property.
my friend who's the director says he used to call it the forbidden triangle because he had this one area.
Well, that's why.
High speed plasma.
That's good. That's good.
That was
Cycles and camp it out to like a rhinitis himself and come back and you're like, oh my god, what have I been doing? Yes.
Was that just
well,
she was over
until
there?
yesterday. They had about 42 inches total.
At the base, but they just try to put it in water. Stephen was already a month ago in the basement and Tony looked at what there's a bunch of rocks out there.
I'm going to be in Chicago for a week.
You got yourself.
Oh my goodness. She was able to get it.
Yeah, it was kind of a rough end.
Let's go ahead and get started. Welcome everybody back from the holidays. I can't complain. I was in Hawaii for a couple of weeks. Before we start, just one unfortunate thing I'd like to mention. Mike Kennedy, a friend and colleague of all of us, his wife has been chronically ill for a number of years, and she passed away this past weekend. I just wanted our community to know that. And a lot of friends in Oregon he has as well. He's been a long time participant in the Northwest Allergy Forum. Today's presentation, Audrey Parks, is sort of timely since we now have sublingual immunotherapy, and this will potentially be, I think, really the first season that we could use it for people with grass allergy. So she's going to give us an update on sublingual.
Thanks. Happy New Year, everyone. Welcome back. So today, as Dr. Almond mentioned, I'm going to be talking about sublingual immunotherapy as it pertains to environmental inhalants, as Dr. Zhang already talked about oral immunotherapy for food allergies. And as just a highlight, some of you may have been already looking at the college-sponsored webinars for SLIT. And there's going to be another one on the 22nd that should be looking more at different aspects of this to get some information on that. So I have no disclosures. So allergic rhinitis can affect up to a third of the world's population, and maybe even higher in some studies as far as in children. And if you look at IgE positive ones to environmental allergies, it can be up to 40%. And as we know as allergists that many of our patients have really suffer on a day-to-day basis with this, and it's a precursor for other diseases such as asthma, and it leads to a lot of missed work days as well, so it sort of has a huge economic effect as well. Pharmacotherapy can provide a lot of relief for these patients, but obviously they have some limitations as far as patients experiencing side effects and having incomplete relief. And so as an allergist, our real main tool, which really provides profound long-term effects, right, is immunotherapy. And this helps even after stopping immunotherapy. And as we know, it prevents disease progression, development of new sensitization, as well as the onset of asthma. So for the long time, subcutaneous immunotherapy was the mainstay, and now we have the tool of using sublingual immunotherapy. And for our pediatric populations and those that are needlephobic, slit really provides an opportunity to reaching out to those patients. And there's also the convenience factor that these patients can take the medication at home. And really slit seems, and I will show you in this presentation, hopefully, that slit provides more safer an option, and as there are fewer local and systemic allergic reactions in its subcutaneous immunotherapy. So how does slit work? So really subcutaneous slit utilizes the tolerant environment of the oral mucosa, and it's really the unique properties and biology of the antigen-presenting cells in the oral mucosa that allows for this tolerance to occur. And so we're talking about the Langerhans cells, myeloid dendritic cells, and the macrophages in the oral tissues, as well as the tonsils and draining cervical lymph nodes. And these allow for the biased induction of Th1 and IL-10 producing CD4 regulatory cells. And in patients who have tonsillectomy, it really doesn't seem like slit efficacy is lost, but you still have the preservation of those lingual tonsils, which is really sort of the local draining aspect of the slit. The oral tissues also have less number of mast cells compared to in the cell, up to 100-fold times less, and so you can have less of those side effects of the swelling and the itchiness. But in the tongue, it seems that the mast cells are more in the superficial mucosal layer, and so you'll see that most of the side effects for slit seem to be sort of tongue swelling local to the oral tissues.
Audrey, if
Yes.
that's true, why do people develop food allergy when they ingest peanuts or equivalent? These mechanisms are in play.
Yes.
You would think they'd be in play with whatever antigen you took orally.
Right. Well, I think part of the process is also just how, if it's actually being absorbed in the oral mucosa. And obviously, it's going to the GI mucosa, which is a different thing, but it doesn't there's the absorption factor that's happening in the oral mucosa may not be as good for bigger proteins. Honestly, I don't know. I don't think everything knows true.
I didn't expect an answer. It's obviously...
Yes. If I knew, I guess I wouldn't be here. So in the oral mucosa, there are various dendritic cells, and if you work from the outer layer into the inner layer, so the first ones are really these oral Langerhans cells, and they're found in the in the mucosal epithelium. And then further down in the junction between the mucosal epithelium and the submucosa are the myeloid dendritic cells, and then finally deeper in the submucosa are the plasmacytoid dendritic cells. But really, in an unflamed, normal, healthy oral tissue, there are very, very few PDCs. So we're really talking about the first two groups of antigen-presenting cells. So the Langerhans cells, they themselves can produce IL-10 and TGF-beta. They also help induce T cells that produce these same sort of cytokines, as well as interferon gamma producing T cells. Similarly, the myeloid dendritic cells pushes the T cells to produce IL-10, TGF-beta 1, and interferon gamma, and then the PDCs seem to push towards an interferon gamma producing T cell. So we'll look more at the oral Langerhans cells because these seem like they're the primary antigen-presenting cell that's important, implicated in how slit works. And the oral Langerhans cells, unlike the skin, really have sort of more of a younger, immature expression of, compared to sort of mature activated dendritic cells. So they have a little bit of the innate sort of phenotype and the innate cells, as well as sort of more classical ones, and that of like B cells of showing FC epsilon expression for the high and low affinity, which are the high and low affinity IgE receptors, which allow for the capturing of allergens. And then furthermore, they also express FC gamma receptors. And so, as I mentioned, usually those downregulate dendritic cells over time. And these guys actually express both the expression of all the time. much all the time constituent. They also express TLR4, and if you go back and remember that that's important for LPS binding, and that leads to upregulation of B7H1 and H3, which pushes more to our tolerance sort of phenotype. So it induces IL-10, TGF-beta, and Tregs and Th1 cells. So knowing that, we can think about ways to sort of skew and allow for more tolerance to occur in the oral mucosa, and so using perhaps adjuvants. And so one of the some of the studies have been looking at various agonists such as monophosphoryl lipid A in doing this, because as of now, SLIT doesn't really utilize the agonists. So much of the studies looking at sort of the immune cells in the oral mucosa have been done in the group of Natalia Novak in Germany. And her group is really interested in looking at within the mouth, actually there's different sort of expression of immune cells within different parts of the mouth. And so they looked at autopsies from patients and took different punch biopsies of different parts of the mouth. So the vestibulum, it's actually the anterior aspect of your oral cavity, so it's bounded by the teeth, gums, and the cheeks. And then the buccal surface, it's your cheek, the palate, the lingua of your tongue, sublingually, and then the gum themselves. And they were staining to look for expression of mast cells as well as these oral Langerhans cells. And you can see here that in the mast cells, the expression of the mast cells seems to be higher in the gum and the gingiva, but lower in the palate and the lingua, and the tongue. When they looked at the sublingual area, interestingly, there seemed like there were accumulation of mast cells within the ducts of the sublingual glands. And so this may account for some of the side effects of the patient's experience with the itchiness of the mouth. And this is showing you a picture of sublingual carbuncle. So that's basically right underneath the frenulum you get swelling. And that's often seen in patients with who are undergoing slit. And then when you looked at the distribution of the Langerhans cells, it seemed like it was lower in the sublingual region, but higher in the vestibulum, in the cheek, and the palate, and the tongue. And then specifically looking at the Fc epsilon receptors, the high affinity IgE receptor, it was actually the highest in the vestibular area. And so if you look at sort of the ratio of the Langerhans cells versus the mast cells, you can think, well, maybe it'd be more advantageous to look at trying to use slit rather than sublingually, but more in the vestibular buccal areas. And so this group looked further at the vestibular region. And here we're staining for CD3, so for T cells, and this is in the skin, the gum, vestibular buccal region, and sublingually. And you can see there is the highest number of T cells in this vestibular buccal region. And when they looked at the cytokines that were being produced in these regions, the oral surfaces seem to have higher expression of interferon gamma and Th17 cytokines versus the skin. And we always think of Th cytokines as being sort of bad and sort of associated with autoimmune kind of things, but also we know that's important in mucosal oral tolerance, and so really you can think of that as a protective sort of mechanism. And when they looked at IL-10 and FOXP3 expression, it was actually pretty similar, surprisingly, in the oral mucosa versus the skin. And when they looked at the transcripts of mRNA, the TGF-beta 1 seems to be actually highest in this vestibular region. And as I mentioned before, these cells tend to have TLF4 expression, so it wasn't surprising to see a higher expression there. So I think the things to expect from this group and maybe in the future, again, is looking at whether SLIT can be utilized not just sublingually, but administered in different ways and allowing for better efficacy. So in further studies by this group, they've tried to address how does the allergen actually bind and get taken up by the oral presenting cells. And so they took oral mucosal biopsies from live patients from the particular region, and they incubated them in a fluorescein conjugated, so fluorescein isothianate, William Protense 5 for 60 minutes. And then they waited 36 hours, and it allowed for the migration of the Langerhans cells out of the tissue, and then they looked to see how much binding there was of the grass allergen. And so they did this taking tissues from actually patients that were grass pollen allergic as well as non-atopic patients. And they did a dose curve looking to see if there was any differences. And so really at the lower doses, you can see there's no difference between the atopic and non-atopic group. There's about 6 to 7% binding. But as you increase the amount of antigen that's there, now there's increase from 7 to 33%, which is similar to the non-atopic group. And then if you increase it further, there seems like there's a saturation, so there's not necessarily an increased uptake of these of the allergen. And so not only is there a dose limitation, which might indicate that there's some sort of receptor binding that's being saturated here, but there's also seems to be a time dependency of this uptake. So when they looked at different kinetics to see how quickly Langerhans cells would take up this allergen, it looked like that it was actually being taken up within 5 minutes. So that's pretty fast. And then this the grass allergen increased the migration of the Langerhans cells. And then when they looked at the cells that were being pushed out, it looked like they were still retaining their immature form. So they didn't have the upregulation of the lymph node CCR7 expression, and also did not express the CD83, which is a marker for dendritic cell maturation and activation. And when they looked to see what kind of cytokines were being produced by the Langerhans cells, it was increased amounts of TGF-beta1 and IL-10, and then if you co-culture them with T cells, it actually pushes those T cells to produce similar sort of immunosuppressive cytokines. So this slide is, again, sort of showing you, and then more the layout, the histology of where these cells are located. So you can see Langerhans cells and the myeloid dendritic cells in the mucosal sort of junction region. And this antigen processing by the oral APC, the antigen presenting cells, seems to occur quickly, so it's within 15 to 30 minutes. And then within a day or two, within a day, they get migrate to the cervical lymph nodes and to the tonsillar area. And then within 2 to 5 days, they go out and seem to induce Th1 and T regulatory cells in the blood first, and then into the mucosa. So what are exactly the immune changes that are induced by slit? And the studies are actually not entirely conclusive. As one might expect, it should lead to sort of more immunosuppressive biases, but some studies actually show the converse, so it's not absolutely crystal clear. But it seems that early on, at least up to 6 months after immunotherapy, you can see some of these TGF-beta and IL-10 producing T regulatory cells in the blood. And that's an important thing to emphasize, that most of the studies have been really looking at the peripheral blood, not looking at the local mucosa, so not necessarily in the nodes or in the mouth or in the lungs. One of the exceptions is actually in this study, they looked in the oral mucosa and they could see that there was induction of OXP3 T cells, which again is a marker for T regulatory cells. But if you use blocking antibodies to TGF-beta and IL-10 early on, so less than 6 months, you can stop the these T regulatory cells' ability to block proliferation, dampen proliferation of other T cells. But if you try to use that later on, so up to a year after slit, then you can't really stop it. So it seems like really it's over time that these changes become more fixed. And so in this particular study, patients were given slit and for grass pollen, and they could see changes in efficacy within a month. But interestingly, that correlation of efficacy doesn't necessarily correlate with actual changes in the immune cells of the CD4 cells. So when they looked at Th1, Th2, Th17 markers of T regulatory cells and the regulatory sort of cytokine production, there wasn't much difference between those patients who responded to SLIT versus non-responders. And surprisingly, too, there doesn't seem that there was much change in the number of Th2 cells there. And then in the B cell compartment, interestingly, SLIT actually increases the number, the amount of IgE in specific IgE up to 5-fold, again in the serum, so not in the mucosa, and it also induces IgG4 and IgA. But if you look at in the seasonal time, so during the grass season, for instance, there's actually blunting of this these specific IgE. So even though there's a total increase in it seems like during the actual pollen season, it is dampened. And then when they looked at the innate cells, one of the highlighting sort of papers kind of showed that perhaps markers such as looking at C1q and stabilin in D cells might be a marker for changes. And so, I mean, it'd be useful to understand how SLIT works, but also, as a sort of biomarker of trying to figure out who is actually responding to SLIT. So when looking at longer after 6 months and further on after SLIT, now you can start seeing the induction of Th1 responses and induction of FOXP3 expression. This seems to be related with genetic modification. So basically, there's decreased methylation of CpG sites and the FOXP3 loci, so it's really changing sort of the access to and the stabilization of FOXP3 transcripts. And then you get decreased Th2 cytokine production, and similarly, as we talked about before, you'll see induction of blocking antibodies and decreased basophil activation. So, really, it'd be nice to know potentially what kind of clinical marker or biomarkers there would be to say, hey, this is a patient who's actually responding to SLIT rather than have to wait for the 5 years or how many years to figure that out. So candidate ones include looking at antibody production, so the ratio of specific to total IgE, ratio of specific IgG4 to IgG1, and then really maybe breaking down that allergen rather than just saying all grass pollen, but looking at the molecular components so that you don't have the cross-reactive epitopes in the way and seeing if there's a better response to those components. And then, as I alluded to before, looking more at the local milieu rather than just in the blood, so looking at the eyes, nose, and bronchi. And then not just saying that there's an increase in IgG1 to a particular allergen, but looking really more at the functional aspect of it. So whether it inhibits binding of the IgE to the allergens to B cells and serum inhibition of basophil activation. So now we come to the 3 different FDA-approved tablets that are available in the U.S. So Oral Air is the grass mix by Allergy, and Crastec is and Ragotec is from Merck. And so Oral Air is a combination of 5 different grass pollens, so Timothy, Orchard, Kentucky Blue, Perennial Rye, and Sweet Myrtle. Whereas Crastec only includes Timothy grass, but as we know, there is grass reactivity between the grass pollens, and so it will react to the ones that are in Oral Air as well as other grass types. And then the Ragotec includes a short. And so right now, the FDA indications for Oral Air is for 10 to 65 years of age. Crastec is for a little younger, starting at 5 years. And then Ragotec's really more in the adult population, so 18 to 65. And the doses are listed here. I try to make them so they're a little bit more comparable. But in the adult population, there's no titration. You just start at the 300 IRs, which is considered index reactivity, the units, which is about 25 micrograms of pollens, of each of these pollens. And then in the younger group, you would start first with 100 and then work up to 200 on day 2 and then finally to 300 on day 3 and subsequently staying in that dose. And then with Ragotec, it's a tablet that includes about 15 micrograms of P5, and the Ragotec contains about 12 micrograms of the A1. And so it's need to start before the pollen season begins. So an oral error recommendation is at least 16 weeks before the grass season, whereas with Ragotec, they're recommending at least 12 weeks. And in the studies, really was looking at before and through the pollen season, and the only one that kind of looked a little bit more at daily and continuous use was in Ragotec, and we'll talk about that study later on in the presentation. And then how do we advise patients if they miss a dose, either they're sick or they forget, they're on vacation, whatnot? And there's not a lot of great information. The studies for oral didn't really count, and then that information was available on what to do. But in the Ragotec and Ragotec studies, in the trials, they allowed for up to 7 days being missed and not needing to necessarily come back to see the physician to do that repeat first visit, but they can go ahead and resume on their own. So contraindications to slit are the following: severe, unstable, uncontrolled asthma, any history of any severe systemic allergic reaction or any severe local reaction to slit, history of eosinophilic esophagitis, and hypersensitivity to any of the inactive ingredients contained in the product. And these inactive ingredients include an oral error. You can see the list here. I kind of looked up what this long named ingredient was, and that's really to help disintegrate the tablet so that it's more readily bioavailable into the system. And then in the studies, they included patients that had asthma, but it was sort of different degrees of asthma. So really, in the GRASS studies, these patients did not have moderate to severe asthma, and these patients weren't on any daily medications in order to treat their asthma. Whereas in the ragweed studies, the patients were allowed to take daily low doses of inhaled corticosteroids. And then as far as our patients who are pregnant right now, the GRASS slit therapies are considered category B, but in the ragweed, Ragotec right now is only it's considered category C. So how do you take the slip tablets? So you need to have clean, dry hands. You remove the tablet from the blister package. You put the tablet under your tongue, and you have to let it dissolve there, and you don't swallow for at least a minute. You counsel our patients not to take any food or beverage for at least 5 minutes following taking the tablet, and to wash the hands thoroughly after taking the tablet. The first dose is recommended being administered in a physician's office that can handle systemic handle reactions, so an allergist's office, and observation for at least 30 minutes. So when do you stop sublingual immunotherapy? So if you have any sort of severe allergic reaction, so no need to belabor the point as we know, but anything like syncope, heart tachycardia, any sort of real respiratory issues, GI symptoms, and sort of systemic cutaneous symptoms such as hives and flushing. And then any sort of oral inflammation, so patients that might have ulcers or thrush or lichen planus, any sort of wounds such as after dental surgery or extraction. And then slit can also be correlated with eosinophilic esophagitis. So if you're suspecting that a patient may have signs of having severe or persistent GERD symptoms, including dysphagia and chest pain, then you may also want to counsel them to stop slit and see a GI physician. So now we're going to go through the various studies in the U.S. That allowed for the FDA approval. And this particular study is for grass tech, and it's the largest clinical trial for slit to date. And it was patients that were in North America, and it was as young as 5 to 65 years of age, and they were randomized to receive grass tech or placebo 12 weeks before grass pollen season. And the primary endpoint is looking at the total combined score. So TCS is the abbreviation you see in the following slides. So that's accounting for their daily symptom scores and their daily medication score. And this study was unique compared to other North American studies because it really only gave the first dose in the physician's office, whereas prior studies had suggested that you do the first 3 doses under supervision of the physician. So this slide shows you a very busy table of the baseline characteristics of the patients who received placebo and the grass tech. And sort of highlighted in boxes here, you can see that about a quarter of the patients did have asthma, but as we mentioned, these patients do not have severe asthma and are not on any medications for the asthma. And then they were polysensitized as well, so they could have other allergies besides grass. But the grass allergy had to be based on a positive skin testing, positive IgE to grass, and they had to have FEV1 greater than 70%. However, they were excluded if they had overlapping symptoms during the grass pollen season. So you could have tree pollen allergies, and so if you actually had clinical history requiring medications for your asthma or allergies, then you'd be excluded from this study. The patients also who are on immunosuppressants for the prior 3 months, except for steroids for allergic and asthma symptoms, were excluded. Any patient with severe asthma and had had any sort of grass immunotherapy greater than a month in the prior 5 years were also excluded. So this is their scoring system of how they figured out the total combined score, and so it's really, you can see it ranges from 0 to 3. And really, when we say placebo, it's really not no therapy. The patients, were allowed to have some sort of tiered rescue medication, so they could utilize loratadine, eye drops of and intranasal steroid spray. And then if they were really severe, then they were allowed to have prednisone, but that score would be included in the total combined score. So in this slide, we see the days and the total combined score on the vertical axis. And these green bars are showing you the total pollen counts over time. And interestingly, in this study, it seemed that the overall grass season was not as brisk as some other seasons. So their mean grass pollen count was only 23 grams per meter cubed, and on average is usually greater than 100. And we'll see in other studies that really that's sort of hard part of doing these is that you're really dependent on how brisk the pollen season is. Which you can imagine if it's brisker, then you're going to maybe potentially see more an improvement or variation of how well patients are responding to the treatment. And then in the little sort of purplish points here, these are the tree pollen counts. And then the open green here are patients who are receiving the grass tech. And then the faint blue is those who are on placebo. And you can see that those that were actually on slit seem to have overall a decreased total combined score. It's up to 23% during the grass pollen season. The common adverse side effects from slit are really local to the mouth, and so you can see that up to about 23% of the patients will complain of some throat irritation, 20% may have some oral itching, paresthesia, 12%, and mouth edema in about 13%, and ear pruritus in 12%. But these are generally early occurring, so usually within a week of starting slit, and they're usually transient and doesn't really require any sort of medication or pre-medication. Over time, these symptoms usually self-resolve. However, there are more noted sort of severe adverse events from slit, in about 3% of those who were on slit versus 1% in placebo. And it seemed to be, again, more locally related. So 19 of the severe treatment-related adverse effects of the treated group were due to local application site reactions. And then only about 6% of the slit group actually had to discontinue treatment due to these adverse reactions. And when they looked at the adverse events over different age groups, it seemed similar, so not any higher, lower, younger, and adult populations, and no real difference between patients who had asthma versus non-asthmatics.
Audrey?
Yeah.
How long do those oral irritant reactions last? So for instance, if somebody's in your office for their 30-minute observation time and they complain of severe oral itching or severe to them and tingling, how long is an appropriate time?
I haven't seen any studies
to watch
or papers saying how long, but my guess is usually not. We're talking about like minutes to hours, not a few hours, not long term. It usually fades. And then this table shows the systemic reactions. And so, interestingly, there was one patient in the placebo group who actually had some reaction of increased congestion and cough. She actually had, this patient, he had asthma. And then two patients who were on the Grastek experienced systemic reactions too. So one had tongue edema, some chest tightness on day 42. But the symptoms actually resolved over 30 minutes without treatment, but this patient actually was removed from the study. And this other patient on day 2 experienced edema of the lower lip, some redness on the mouth and chin, some GI discomfort, and again, resolved in an hour without any intervention. And then there were some patients who actually did use epinephrine. Again, there was, interestingly, one patient in the placebo group who received epinephrine, and there were only 3 that were in the slit group that received epinephrine. One for some sublingual swelling, which led to heaviness and shortness of breath. And this particular patient here had some initial some swelling in the throat, but without any difficulty breathing or swelling, but it was minor and didn't really tell any parent that he was having these symptoms. And then in this patient, who was 65, had some itchiness around the mouth and some throat irritation. And then eventually, very slowly progressive throat tightness, lip and facial swelling, and hoarse voice, and received epinephrine. So similar to that large study, there were 2 other studies looking at Grastek, and it showed similar sort of improvement in the total combined score. So about 20% in Nelson's group, and in this Blaze paper, it's a 26% improvement. And I just kind of highlight here because there's sort of different standards of what we consider efficacy. So the FDA mandates that you have at least 10% efficacy above 95% confidence interval in mean TCS, so total combined score difference versus placebo, and at least a 15% improvement in total combined score. Whereas in other organizations, sort of the World Allergy Organization suggests that you have at least a 20% improvement, but regardless, with these studies seem to meet that 20% mark. And in these studies, too, again, it's more local sort of irritation. There was only one patient in Nelson's group that required epinephrine and had that early on day 1. And similarly, in this Blaze paper, there was another patient who had received epinephrine on day 1 due to lipedema, dysphagia, and cough. And then this study looking at the combination oral error. So what's interesting about this particular paper is that usually the patients that are included are ones that are positive to GRAS based on skin and IgE. But here they were only picking those that had positive skin testing, although they did measure IgE to GRAS as well. So those that were positive but didn't have any detectable Timothy GRAS IgE, there were about 11% of those patients, and they did not respond to slit, and they didn't have any symptoms during grass pollen season. So it may be something to think about in our patients. We were trying to figure out who would be a candidate for slit. But with the oral air, there was a decrease in the combined score of 28%.
You're going to compare that level of efficacy with subcutaneous?
Yes, so I'll show you some. Those are hard studies, but there are a couple that I'll show.
Why did the oral air study have kids start low dose and go up? Was it because of a question of systemic, or was that just study design, so they were locked in for that?
Yeah, I think they were locked. They didn't tell the reasoning for that.
But it's a lot. It's a higher dose. It's 25 versus 15.
Yeah, but they had more
each.
reactions. Is that why they did it in kids? Because you don't do it in adults.
Yeah. Right.
What's different about kids? I think I bet it was just study design.
Did they study people with oral allergy syndrome?
Yeah, that's a good question too. They didn't. So that would be another sort of marker of efficacy whether that helps or worsens in any way.
Thank you.
And then this is a slide shows us a summary of the U.S. trials for slit to ragweed. And so, as we know, the ragweed tech contains 12 micrograms, so they were actually looking at the different doses down to 1.5. But up to in the 12 microgram group, they had up to 27% reduction in their total combined score, as opposed to the placebo, which again, patients are allowed some medication for their symptoms. Again, it's more local sort of reactions. There were no serious treatment-related adverse reactions. One patient who did receive epinephrine for a sensation for pharyngeal edema on day 22. And then, the studies so far that I've been talking to you about is more for tablets, but as we know, there is sublingual liquid as well. And this is one of the few studies that actually showed that it can be efficacious. This is to ragweed, and they saw up to 43% reduction in total combined score. So how long do we put a patient on for slit? And there are really two good studies kind of address that question. And so this is for patients using grass tech. So rather than just doing it during the grass season, they were doing it continuously for a total of 3 years, and they followed these patients for 2 years afterwards and to look at their responses. And so the white bars are the placebo, the black is those patients who are actually on slit. And you can see that between 33 to 41% decrease it's when they're actively taking it. Then when they stopped, there's still improvement of the combined score of patients who have received slit. And this is just sort of highlight again the importance of how brisk the pollen season is, because in the second year follow-up, there actually was a 30% decrease amount of pollen compared to the first pollen follow-up year, and which was 38% lower than the first season one. But overall, still, there was a longer acting effect up to 2 years after stopping slit.
That's European data.
Yes.
Right.
Yeah. They call theirs Grazax over there, but it's grass. It's the same thing. It's grass tech. And then, so this slide sort of emphasizes the point that really there is a correlation between the control of symptoms and the pollen count. So you can see that when you have increased pollen count, you'll see increased reduction relative to placebo. And so really depends on how intense, so how high the pollen season will be on a given day, the onset, how abrupt the onset of the pollen season is, to sort of see if the grains, and the allergenicity can also be increased by interaction with air pollution. So this is another study sort of looking at a question of how long to do it, and this study looked at dust mites slit immunotherapy, and so they were in adults 18 to 65 years of age who are only monosensitized to dust mite. They could have asthma or not have asthma, but they had to be requiring no sort of medication, very mild asthma, so their FEV1's greater than 80%. Patients were either given dust mite slit 3 times a week, were controlled, and so the doses here are, you can see that the dose is about 10 times greater than in SCIT. So this is for patients who are taking SLIT for 3 years, SLIT for 4 years, and SLIT for 5 years. And the colored lines are SLIT patients on SLIT versus the black lines that are on control. And you can see the total combined symptom score on the y-axis. And so in this study, they were given SLIT, and then for the 3 years, and then you can see after about 4 years, these patients start having relapse in their symptoms. But if you give them SLIT again, the symptoms really drop pretty briskly, maybe even a little bit more so than the first time. Whereas patients who were given SLIT for 4 to 5 years took about 1, 2, 3, 4, 5, 6 years before sort of increasing, relapsing with their symptoms. So these authors suggest that the optimal duration of SLIT would be at least about 3 years. SLIT also seems to decrease news sensitization. So this is looking over a 15-year period. And on the y-axis, you can see the percent of patients with at least one new skin test positive to a new allergen. And so this is the control. And then those that are on SLIT really are hugging on the low end, less than 20%. So only a quarter of SLIT patients developed new sensitization, so 21%, and those took 3 years, 12.5% took 4 years, versus 11.7% took SLIT for 5 years.
Audrey, in all these studies, are they on SLIT all year long, or did any of these do the seasonal?
Yes, some do. So the first one, the very big study was just seasonal and before and during grass season. But these are the two real big studies that try to address looking over time, continuous use of it, how will that affect the patients. And then this slide shows how SLIT can actually improve asthma as well. So it decreased hyperreactivities using ethylene. So again, the black is the control, and then the blue is for 3 years, the red is for 4 years on SLIT, 5 years is the green. And you can see that basically, again, after about 4 years after stopping SLIT, 3 years, that you sort of get relapse in symptoms, more sensitive to the methacholine, whereas it takes a couple more years for those who are on SLIT for 4 years, and those took actually for 5 years, really don't drop as precipitously, and here they're restarting SLIT, which is why they're having improvement. So then SLIT may be also helpful in atopic dermatitis, but the studies, again, are very poor and scant. This is one of the studies in Jackie in 2007. It was the only double-blind randomized controlled study that it could find evaluating SLIT for treatment of atopic dermatitis. So it was looking at kids 5 to 16 years of age with atopic dermatitis, and they used the SCORAD score, so it's looking at the extent and severity of their eczema. So they could have who were dust mite sensitized, and they could have other sort of atopies such as food allergies or chronic asthma. These patients were receiving SLIT in these particular concentrations, and that was 3 times a week. Initially, they had 56 patients that were, and then half were given placebo and half were given SLIT. But at the end, only 48% had completed the study, so 26 in SLIT and 22 were in the placebo group. And it showed that SLIT really decreased the need and requirement for medication use. And then there was a decrease in SCORAD, so again, the atopic dermatitis score, starting at month 9. But when you break down the severity of eczema, it didn't seem as crystal clear. So basically, those patients who had mild to moderate eczema seemed to respond better to SLIT compared to placebo. However, if you're really severe with eczema, then you don't get that nice clear delineation and improvement in response to SLIT. So in fact, 2 patients on SLIT had to stop it due to worsening of their eczema. So what The safety of slit overall, it seems like it's much safer than with skit. So as of 2012, there were only 11 cases of anaphylaxis in slit, an estimated 1 billion doses given worldwide. And then, as we know, subcutaneous immunotherapy poses an increased risk of and up to 3 events for every 100,000 injection visits. And then slit also has the advantage of not eliciting de novo IgE responses to allergens for which the patient is naive before treatment. So prior studies had shown that if you were given house dust mite subcutaneous immunotherapy, some of these patients actually developed cross-reactive, tropomycin-reactive IgE, and so they would have some oral allergy symptoms to shrimp. But really, it looks like what we see so far is that slit does not elicit that similar kind of problem. So what are the risk factors? How are we going to predict who's going to fail or have problems with slit? And because it's relatively safe, there's such a small number that you're looking at, it's hard at this point to determine what are the predictors. But one might assume, and it seems to suggest that having a history of a prior reaction to subcutaneous immunotherapy may make you more at risk for having a reaction to slit. And actually having a history of asthma also poses a risk. But then the actual modality of what kind of slit formulation is giving, so whether it's tablet or liquid, doesn't seem to correlate between as far as causing risk or severity. And so big sort of controversy is whether right now the inserts for these FDA-approved slit products suggest that we prescribe and provide teaching for epinephrine autoinjectors for patients prescribed slit. And so in the European community and the rest of the world, that line's not included. As a reminder for us physicians, remember that epinephrine has different sort of effects, and so thinking about what kind of medications the patient may be on that potentiate or inhibit the effects of epinephrine, including alpha beta blockers and antidepressants, thyroid medication, in particular antihistamines. And then those patients who are on cardiac glycosides and diuretics would be potentially more at risk for having some sort of arrhythmia as well. So the pros for potentially for prescribing the auto-injectable epinephrine slit are the following: is that there is a risk, although it's rare, and so protect those patients. And since slit is a home-based therapy and there's not a medical practitioner there who can assess a patient, then it would allow, obviously, for that patient to have quick access for help. And then there's sort of medical legal concerns. You have this insert that says you should be doing it, and if you don't prescribe one and they have a reaction, what would that mean? And sort of the cons would be that, well, it is safe, so there's really just mild adverse reactions, or systemic reactions aren't very severe. There are no deaths reported, so why would you prescribe something that's very expensive? And then in a recent paper in the Annals showed that up to 16% of patients actually only correctly know how to use their epinephrine auto-injector. So are they going to be injecting their thumbs? Are they not going to be doing it right? Are they going to be holding it for an appropriate amount of time? And as I mentioned before, those auto-injectors are not required for patients who are in slit in Europe and Canada. So one might think that the compliance with slit would be better because now you're taking it home and you don't have to worry about trying to make time to get to the office and get there at a certain time of hours. But surprisingly, the data seems to show that that may not be true. So in up to 76% of German patients, 82% of Dutch patients actually abandon slit before reaching the targeted 3-year mark. And then in the U.S. allergy practice Northeast, they have patients who are on skit and slit, and only 23.7% of slit patients completed the 3 years, as opposed to a higher number of that were on skit. So 35% actually completed their course. So how do we improve compliance? So really, again, it's all about communication, letting our patients know what to expect, what side effects there are, how quickly we may expect to see improvement in their symptoms, and doing regular and frequent visits. So having the patients come during the pollen season, making sure that they're taking it and seeing how they're doing with their treatment. And then now that we're in this electronic age, that we can use emails and texts and the old standard way of actually phone calling them and making sure they're compliant with their therapy. So, Dr. Almond, you had asked about the sort of comparison between slit versus skit, and there are really very scant articles on this particular topic too. And so I'm going to highlight 3 articles that try to address that. So in this IPM study in 2010, it was a randomized, open-controlled study, and so these were patients who were monosensitized to dust mite, and they had mild persistent asthma and rhinitis. And here it looks like there really wasn't much difference between skit and slit. They had significant reduction in the total rhinitis and asthma score, the medication score, and there were no adverse really events for patients who were slit. However, there were adverse reactions in those who were receiving skit. And then in this particular study, it was kind of interesting. They looked at patients who received skit versus slit, and then since this was a pediatric population, and they said, well, why don't we try giving them skit first, and then using slit as a maintenance dose way of trying to tolerize these patients. So these were patients who are 5 to 12 years of age with mild persistent to moderate asthma and rhinitis, monosensitized to dust mite. And then they looked at the sort of the amount of inhaled corticosteroid dose, the number of asthma attacks, and they looked at various sort of profile of the various cytokines, antibody production, to see if there was any changes. So pharmacotherapy. So basically, pharmacotherapy. So as I highlighted before, really there's never a placebo because of sort of, can't leave the patient suffering. So there's always the patient. No. It's a Hawaiian brain. Hawaiian sun. So immunotherapy schedule is here, so you can see that the patients on slit were receiving the dust mite 5 drops per 3 times a week. And then the skit group were receiving the following doses, and then the skit plus slit group would get 16 weeks of the standard skit, but then would continue with 3 times a week of sublingual. So here we can see the different months after being on the various immunotherapy or not. And here is the dose of the inhaled corticosteroids. So in the skit group, pretty quickly within 4 months, you can see a significant drop in the amount and need of inhaled corticosteroids, whereas it took up to 12 months before you could see that significant difference in patients who were on slit. Patients who received skit and slit didn't necessarily have an increased change, but again, it was brisk by 4 months as opposed to the pharmacotherapy group, which had a constant need for same thing. Yeah.
A couple slides back, you showed the difference in total doses between slit and skit, and if you look at this data, the skit stuff looks obviously different than the other. Have they correlated actual total doses between each other versus just duration of therapy?
It's hard to do the doses. It seems that with slit, you always need a higher amount, and I don't know why that necessarily is. So it's hard to say. I don't know if it's the way the uptake is, or but it's always going to be higher. So you can't. It's like apples and oranges. You can't completely compare between skit and slit doses.
So nobody's tried to do that and say with equivalent doses this
correct. Yeah, I mean, we do, but they are different. I mean, there's great variability. It's like 10 to 100-fold difference. But and then this is looking at the number of asthma attacks. And again, in the skit group, you see that there's decrease within 4 months of immunotherapy, whereas in the slit group, you really only see it for this 1 month, but overall not that huge of a difference. And then improvement, similar in a slit group compared to those who were just receiving skit alone. And then this is looking at the visual analog score, so sort of emphasizing the point, so patients' sort of symptoms for experiencing asthma and rhinitis. And again, those who are receiving skit seem to have early improvement by the 4th month, whereas in slit it seems to take a little longer, to about 12 months. But interestingly, in the rhinitis group, really you don't see much change except by the 12 months for skit. Rhinitis analog score and combined therapy allows for sort of improvement by the 4-month mark. So then they looked at the immune sort of parameters and to ask whether there were any particular changes. And really the total and specific IgE to the dust mites in the groups were pretty similar. The amount of antigen-specific induced IL-10, TGF-beta, and interferon gamma were similar in all the immunotherapy groups. And then when they looked at the DERPI-1 specific IgG4, it was much, much higher, as you can see, in the skit group versus those that were on slit and combination therapy. So they asked, well, can you correlate these immune responses symptom medication score? And there was some positive correlation. So if you have more IL-5, then these patients would tend to have more symptoms for their rhinitis and asthma. And then a negative correlation would be those that have higher levels of TGF-beta, interferon gamma, and DERPI-1 induced IgG4. But then another study said, well, maybe if we just waited longer, would you actually see more improvement? And so like this paper looked again in children from 7 to 14, looking at immunotherapy to dust mite. And when they looked at the 2-year mark, and it did seem like slit was more helpful in reducing the symptom scores to asthma and allergies, but still skit did a little bit better, a little faster than slit. So what are sort of the unresolved issues? I mean, there are many that I kind of highlighted already in the talk, but other ones that I haven't talked about are the following. So what is the optimal dose of allergen needed? And it's difficult because in the European studies, they're using all different kind of units. Each company has their own sort of in-house unit that they use. So it's hard to really compare between studies to say, well, okay, the dose is similar or not. And each company also has different potencies, so it makes it difficult to extrapolate from one study to another. And then really what we want to be able to tell our patients is this going to help you overall, and especially our children, pediatric population in the atopic march. So this year, hopefully we'll be getting some results for the GAP study, the grass asthma prevention trial, which is children ages 5 through 12 who are on grass pollen, who have grass pollen allergies and are on slit for 3 years, and they're followed for 2 years to see the primary endpoint is the time to onset of asthma. And then most of the studies I've shown you are for 5 years and older, so what about patients who are younger than that? And there are some studies that seem to indicate that using it younger is still efficacious. So would that be more helpful in preventing those patients as they work towards the atopic march? And then finally, the European data, as we know, is really looking at patients who are monosensitized, which is not what patient population that we're dealing with here. And so what happens when we start mixing a bunch of different antigens all together is there's some risk of degradation of that product because there are proteolytic enzymes in there that might degrade the product. And as I talked about, there's the uptake in the oral antigen-presenting cells are very important. Are there enough in our mouth that will allow for all those allergens to be taken up? Is there going to be competition in that niche? And one of the studies seemed to suggest, well, maybe it could be a problem. So in this study, compared to placebo, Timothy grass monotherapy increased the threshold for nasal challenge, skin test positiveness, and test tube grass, and serum-specific IgG4. But when they included in that slit other allergens, so these patients, whether or not they were sensitized to true grass, they threw 9 other allergens in, then it seemed that it only helped with reduction of the skin test and not necessarily the other the parameters. So we'll be sort of watchful waiting and seeing how this all plays out and how we can help our patients with multiple sensitizations. That's it.
Audrey?
Yes.
Although there weren't any comparative trials, just through your reading, do you get a sense as to if pre-seasonal and seasonal therapy may be just as efficacious?
Yeah, there was a study trying to look at that, and it seems like it could be helpful as well. But I think, again, it's not enough data, so we need more data, bigger trials to kind of emphasize that point.
And am I thinking of this correctly? Here in the Pacific Northwest, are we thinking of like 8 versus 12 months of therapy? If you start 4 months prior and then you treat for 3 to 4 months, or am I not thinking of this correctly? You know what I mean? Is that what we're talking about, 8 versus 12?
So you would start like January, February-ish time, and then go all the way through.
And then you go like April through August?
Yes.
Or
Yep.
7 versus 12.
Yep. So we're
7 versus
talking
12.
now.
Right.
Audrey, not to pin you on the spot, but is there any comparison between oral air and breast head to head?
I have not seen that data.
And the second question is, looking at your data, wouldn't it make sense to put these people on long-term once a week or once a month therapy because they blow up at 5 years and then they come right back down as soon as you start?
Right. I think that's probably where things will play out. It looks like using it for longer term is more helpful.
So instead of 8 months on, 4 months off, it may be just 8 months on and then 4 months of just baseline.
That's what it seems like right now. Again, there are really only 2 studies suggesting.
Thank you.
Great job. Thank you.
Does most of the initial itching resolve within an hour? I mean, most of us want to use this. Yeah, I mean, are you able, so after an hour, your patient's still saying they got all these symptoms and they're not?
Right. I think Dr. Eczema had asked that question as well, and I'm not sure that exact duration, but I mean, they say it's pretty much self-limited, so I would think minutes to only a couple hours at best, but really that's an important part to tell our patients that to expect this, not to necessarily go rush and use their EpiPen at that point.
But they could go home if they're in your office and they're still itching after an hour, or repeat.
Yeah, I think that's going to be a physician call and, you know, the level of comfort for that patient too. Yeah, it's tough. It's tough. All right, thank you, everyone.
And then do you, like, is there
I
Did
think
I
there
get
is.
this shit?
Yes,
Okay.
I believe there is.
And then I think we're meant to do, like, tell them at the end how many times we call.
Oh, yes, yes. Yeah, I remember vaguely there was an email about what to do. And I'm like,